Okay, everyone. Hi there. My name is Fawad. I'm one of the gastroenterology registrars, and the presentation I'm doing today is on hepatorenal syndrome. So I've been told to wait until 105, so I'll stop presenting in a minute. It's 105. So essentially, hepatorenal syndrome is a term that I commonly see in notes where people essentially label it on people who have renal disease and liver disease. So a lot of people who have liver disease coming in with an AKI get labeled hepatorenal syndrome pretty early on, quite commonly we see, but the actual definition of hepatorenal syndrome is a bit more complex than that. Essentially, it's really a diagnosis of exclusion. So what you want to do is identify a patient who has advanced liver disease, who has no reversible or identifiable cause of renal failure before you label them as hepatorenal syndrome. So essentially, hepatorenal syndrome as a concept has existed for a very long period of time. Over the last few years, there's been some changes in how we describe people with hepatorenal syndrome, how they're labeled. So in a lot of textbooks, hepatorenal syndrome is commonly sort of categorized into HRS1 and HRS2, which I will show in the slide next. So HRS1 in a textbook sense is the kind of HRS patients who we see being admitted to hospital. They're patients who have an insult on the background of having liver cirrhosis, presenting with a significant AKI, obviously requiring quite invasive testing and interventions. HRS2 are the kind of patients that we normally see in clinic. So they're the patients who don't have an acute AKI, who slowly have declining renal functions. Commonly, they'll have very difficult to treat ascites. So those are the two kind of classical definitions of HRS1, which is the ones that we see as inpatients, and HRS2, which is what we normally see in outpatient settings. So the previous diagnosis of HRS required quite a few criteria. As we said before, it has to be people with established liver disease who have advanced liver failure. So people having a cirrhosis with ascites was the first criteria. The second criteria was that the creatinine had to be above 133. And then all the other things you see listed in this presentation, essentially trying to exclude identifiable causes before you label them as HRS. So you had to make sure that they had no evidence of shock. They were not hypovolemic. All of these patients with liver cirrhosis are commonly on multiple different diuretics, including spironolactone, furosemide, a lot of other medications, commonly nephrotoxic. So you really want to identify patients with advanced liver disease, make sure there's no identifiable reversible factors. And then once you've done all of that, that's when you start labeling them as HRS. So this is the previous kind of classification you'd use to diagnose people with HRS1. So the new classification, it's quite similar to the previous classification. The main difference was that we recognized that we were labeling some people as HRS a bit too late. So rather than waiting for the creatinine to be above 133, what they changed it really was you still had to have advanced liver disease, so you still had to have cirrhosis with ascites, but your actual cutoff for labeling people as HRS had changed from being above 133 for HRS1 to just having either an increase of 0.3 milligrams per deciliter, which on our system would be about 26, so a rise of creatinine of above 26 within a 48-hour period, or a 50% increase from whatever their baseline was before admission, or the presence of a reduced urine output over a 6-hour period. So that's kind of the main change between the old classification of HRS type 1 and HRS AKI, which is essentially replaced that category. All the other things are pretty much exactly the same. You still had to have liver disease. You still had to stop any offending medications, still make sure they weren't hypovolemic, give them albumin. So the recommended dose of albumin is 1 gram per kilogram of body weight. So just to give you guys an example, 20% human albumin solution, which is commonly the agent we'd use, has 100 mils, has 20 grams of albumin. So if you had someone who's 60 kilograms, you'd give them free loss of 20% HAS on a daily basis. So very similar principles. The one thing you'll notice that we commonly don't really do, I've worked in quite a lot of different liver centers, we really don't check urinary sodiums at all as a concept, to be honest, to kind of differentiate between acute tubular necrosis and HRS. So if you look at the list about the protein and the blood, one of the things is checking a fractional sodium excretion. So essentially people with acute tubular necrosis will have high urinary sodiums, and people who have HRS will have low urinary sodiums. That's kind of the one thing that we just don't really do that much of, even as on gastroenterology wards, liver wards, I've seen urinary sodiums being quite underutilized. So that's one thing I've noticed. So as I said before, a lot of this is very technical stuff, to be honest. HRS1, HRS2, but at least identifying what we mean by each of these terms is quite important, so they can be appropriately managed. A lot of people with liver cirrhosis come in under the acute take, and there will be a period where sometimes over the weekend there won't be a gastroenterology doctor who can kind of identify who is HRS AKI and who isn't. So it is quite important to sort of understand these figures. And if you look at the classification system, HRS1, like I said, is the inpatient one that we need to be aware of, being replaced by HRS AKI. And then you'll see the HRS2, which was the slower progressive decline, has also been subdivided. So HRS and AKI means non-acute kidney injury, and that's been further subdivided into HRS AKD and HRS CKD. So I will now go to admit these people, and then this is how they subdivide it. So HRS AKI we've already gone through. HRS AKD and HRS CKD, all it really tries to distinguish is these are the patients who do not have an acute kidney injury, and you're just trying to figure out whether it's someone who has kidney deterioration over the last 3 months or if it's been present for more than 3 months. So HRS AKD, essentially your patients who have an eGFR less than 60, seen in the outpatient clinics who have no reversible identifiable cause of the AKI, and it's within that 3-month period. So that's kind of the period where you could potentially have more interventions available to offer them, whereas HRS CKD are the patients who've had this going on for a longer than 3 months duration. Most of these patients are much more further along in the disease process. So like I said, with cirrhosis, try not to label them as HRS at the front door. Consider them like any other AKI patient. So you still have to consider your diagnosis as if they did not have liver cirrhosis. That's the first thing. So obviously, patients with liver cirrhosis are on multiple different diuretics commonly. They are commonly on a lot of other nephrotoxic medications. They commonly get infections. So there's a lot of different reasons why they could have an AKI. So if you look at this list, essentially, it's exactly the same as any other list, apart from that it differentiates between acute tubular necrosis and pre-renal AKI, and renal causes more. So through the front door, make sure they're not hypovolemic, stop any nephrotoxic medications. A common questions that juniors ask me is what to do with your patient who has both peripheral edema and ascites and also has AKI. Everyone always worries about giving them fluid and making that worse when they have quite a significant AKI as well. The general rule of thumb that I tell people is obviously it's not ideal. People who have HRS have poor prognosis overall. You have to pick and choose which one of those things is the most significant thing that you need to treat at that given time. So the majority of patients with cirrhosis who present with AKI, it's actually the AKI which is the problem. So I would almost always advise people to give albumin and give fluid, even if your patient had large volume ascites and a lot of peripheral edema, because we can always put an acidic drain in if you fill them up and the AKI improves. So I've had people who come in with large volume ascites, peripheral edema. We still tell them to give fluids. We accept that they will probably need an acidic drain as an inpatient. Sometimes I've had people who have HRS. We literally fill them up and then afterwards you put them on furosemide infusions. It's not ideal. Obviously, when you have two conflicting dilemmas, you just have to pick and choose which one of these is more important. Sometimes they can get even more complicated. Some of these patients have dilated cardiomyopathies because of their alcohol use, and then they go into pulmonary edema. Then it's even more of a challenge, to be honest. I mean, if you have someone who's got HRS and is in pulmonary edema, that's probably a time where you should call palliative care. But I mean, it's not an easy thing, but generally the rule of thumb is as long as they don't have pulmonary edema, we always try and prioritize the AKI part rather than worrying too much about the ascites. So just like very similar to pretty much any other AKI, if you think the hypovolemic, given fluid expansion, that could be either crystalloids or 5% human albumin solution. Post-renal AKI is quite rare. It's similar causes to any other AKI, obstructive uropathy. The one thing we sometimes notice is that people with tense ascites can have a degree of compression where after you actually drain them, their kidney function improves. The AKI and acute tubular necrosis, like I'm doing this presentation, but I'll be honest with you, I really don't think that much about acute tubular necrosis. I've already told you guys that urinary sodiums aren't really a thing that we do that commonly. Most guidelines do recommend doing it properly, identifying who has acute tubular necrosis, who has a pre-renal AKI, who has HRS. But like I said, that's probably one learning point for me specifically, is kind of work up more on that side of things. So if you look at disclosure about how you'd go about treating these patients who present with AKI, it's pretty much like any other AKI patient. You first of all assess their fluid status. Are they hypovolemic, euvolemic? Like I said, keeping in mind the caveat that they can be intravascularly dry with ascites and with peripheral edema. Most of the time, we would prioritize the AKI rather than the fluid overload side of things. So discontinue diuretics. One important thing is that these patients commonly will present with hyponatremia. Obviously, if you have a patient with a sodium less than 125, we would not continue spironolactone. So it's a lot harder to manage than a lot of the other AKIs because hyponatremia commonly comes into the equation as well. So you'd make sure they're euvolemic, give them albumin as recommended. Also consider intrinsic causes. A lot of these patients on stuff like spironolactone can have renal tubular acidosis. They can have a lot of different nephrotoxic medications, so stop all of those. Get an ultrasound abdomen. And most of the time, these patients who come in through the front door, we'd want to reassess the liver anyway to see if they've developed hepatocellular carcinoma, to see if they've got a portal vein thrombosis. So at the same time, it's probably a good idea to look at the kidney to make sure there's no obstructive uropathy as well. After 48 hours, if you looked at those guidelines from earlier, that's really when you reassess. Once you stop the nephrotoxics, once you fill them back up, if it's resolved, then it's most likely a pre-renal AKI or an AKI secondary to the medications. If it still persists, that's when you label them as hepatorenal syndrome. Obviously, this divides it into acute tubular necrosis and hepatorenal syndrome depending on the urinary sodium. So if you have a high urinary sodium, it goes into the ATN category, where obviously the management would not be the same as that of hepatorenal syndrome. It would be mainly a supportive management rather than going along the lines of the hepatorenal syndrome. And with hepatorenal syndrome, it's really two agents that we recommend. So the first is we recommend albumin on a daily basis, minimum 2-3 lots of 20% HAS. Alongside a vasoconstrictor. So the commonest one we use on wards is terlipressin. There's a slide, a few slides later, which will tell you about the doses and stuff. So essentially, once you started people on terlipressin albumin, you'd have to check their use needs on a daily basis, monitor the urinary functions on a daily basis. And by this point, obviously, if you have someone on the ward who has advanced cirrhosis and has hepatorenal syndrome, it's always a poor prognostic marker. So renal replacement therapy is an option that you guys should keep in the back of your mind. But at this point, most of these patients do have a very, very, very poor prognosis. So pathophysiology-wise, this slide shows you what normally happens. So essentially, you'll see that there's a few negative feedback loops which actually make the overall management of hepatorenal syndrome much more complicated. So patients with cirrhosis develop portal hypertension. Portal hypertension causes flank vasodilation, which means that the blood supply to the rest of the body is actually diverted towards the portal system, which actually causes central hypoperfusion. It causes activation of the renin-angiotensin system. That causes the hyponatremia and the fluid retention, which increases the cardiac output, which increases the blood flow, and then it kind of goes into this negative feedback cycle, which causes kidney dysfunction and ascites. And it's actually quite difficult to break through the cycle. So that's why most of the time patients with hepatorenal syndrome have pretty poor prognoses. Risk factors for developing hepatorenal syndrome. Obviously, anyone with advanced liver disease who presents with infections, particularly SBP, they have a very high risk of developing HRS. So our protocol normally is that if you have a patient who has confirmed SBP on day 1 and day 3 of their infection, we would give them a high volume of albumin regardless of their kidney function to prevent them developing HRS. That's a separate thing altogether, but if you have a patient with SBP, we do give albumin on day 1 and day 3 to stop them developing HRS, regardless of what their kidney function is on day 1. The overall prognosis is very poor, so this is something that is quite important. Once you're getting to the stage of diagnosing HRS, you should always be thinking of palliative care, telling the family, being honest with them that all the studies that we have currently are suggesting that the overall prognosis of these patients is very, very poor. HRS1 has a particularly poor prognosis, so HRS-AKI similarly has a poor prognosis. So palliative care by the time you're diagnosing this is actually quite important. Preventing HRS is very, very difficult because most of the times you will see these patients who have both declining kidney function and worsening ascites. The ascites and the peripheral edema commonly limits their quality of life. You obviously want to keep a control of that, but sometimes you have to use huge amounts of diuretics to try and control that side of things. Then if anything else happens, like an infection, a chest infection or SVP or anything else, they'll come in, they'll be on a huge amount of diuretics, they'll be sick, and then that is kind of a recipe for them eventually developing HRS. So obviously, if you have someone with liver disease with a reversible etiology, so the patients with alcoholic liver disease, the best thing is asking them to stop drinking, letting them know that if they keep on coming in and out of hospital, the next time might be the time that they actually pass away. Preventing decompensation, again, is quite difficult. We try and keep them on the minimum amount of diuretics needed to achieve the treatment goal that we want. Avoiding agents, I will cover in a few slides, and preventing factors that impact circulatory status, I will also go over in the next few slides. So role of prophylactic antibiotics in albumin, there's quite a lot of current studies being done, especially in Europe, looking at outpatient albumin for patients with liver disease. It's something that's currently being investigated. No significant evidence currently is available to suggest that that's something that we should be doing as a routine thing. The one thing that we do know is that after patients do develop SBP once, we always keep them on prophylactic antibiotics because the chance of them developing SBP again in the future is very high. The other thing we also recommend is patients who come in with variceal bleeds or suspected variceal bleeds. The reason why we recommend giving them IV tazocin on admission is because of the risk of bacterial translocation. So the main reason we give the tazocin to patients with variceal bleed isn't specifically anything to do with the bleed. It's the high risk of them getting bacterial translocation and then developing SVP. So if that's something you had as a question, that's mainly the reason why we recommend giving IV antibiotics for variceal bleeds. Yeah, that's why I was going over. So in terms of specific medicines and HRS, so beta blockers are something that we're increasingly using quite early on in patients with liver disease. So a few years back, mainly we were using beta blockers for patients with esophageal varices, which did not meet the criteria for banding as a tool to reduce the risk of rebleeders after we did intervention in certain patients. Nowadays, we recognize that beta blockers have much more of a role before things happen. So there's quite a few studies looking at primary use of beta blockers in patients with portal hypertension. They're very, very useful for a number of different factors. However, one thing that we have noticed is that patients who present with HRS who are on beta blockers should probably have their beta blocker stopped. So if you have someone who's presenting with decompensated cirrhosis, it's particularly advanced and they're developing HRS, during that period, it is recommended that we do stop the beta blockers because it could cause a decrease in cardiac output. That's kind of similar to the previous slide. NSAIDs are a definite no-no. So if you have a patient with cirrhosis and they're telling you they're taking ibuprofen, you definitely need to tell them the importance of not taking ibuprofen. First of all, in terms of bleeding. Second of all, for the kidneys, it's a complete no-no. So NSAIDs are really the last medication we'd recommend to anyone with established cirrhosis. ACE inhibitors and ARBs is a bit of a difficult one. So obviously, they have such a good use in a lot of different comorbidities. A lot of patients with cirrhosis have multiple different comorbidities, including LV dysfunction, hypertension, other cardiac etiologies. So ACE and ARBs are quite useful in a lot of those things, but the studies looking specifically at the liver suggesting that it's not as ideal for our cirrhotic patients, but it's not as clear-cut as you should use them or you shouldn't use them. It's kind of more of a balancing thing. If you have enough of a good indicator to use ACEs or ARBs, you should still continue using them. As a primary single antihypertensive, probably would recommend going with something else. But again, there's not a clear-cut answer, to be honest. Aminoglycosides, this is again another one. If you have someone who's profoundly uroseptic with an organism which only responds to gentamicin. I mean, gentamicin is one of the best bactericidal antibiotics we have. You'd be justified using it, but the general recommendation from EASL is only really use it in the ones that you can't treat with any other antibiotics. That's it. Again, it's not a clear-cut scenario. If you have someone who needs gentamicin, you should give gentamicin, but if it's other options that are available, would recommend you use other options. Diuretics, like I said, if you have someone who has HRS, diuretics should be stopped as a general rule of thumb. We can always do drains. We can always diurese them later on once the AKI is improved. It's, again, a hard one, but my rule of thumb is if you have AKI and fluid overload, focus on the AKI when they first bring it to hospital. Then specifically to HRS, as I was saying, tertiary present albumin is what we mainly recommend. In America, they use octreotide and midodrine more than we do here. Noradrenaline is an agent that you could use if your patient was on ITU, but the ones on the ward setting, it's mainly terlipressin and albumin. So how we give terlipressin, the commonest starting dose that we tend to go is 1 milligram QDS, and then up titrate it further if there is an inadequate response. So terlipressin, continuous infusions, I've never seen anyone give continuous infusions. It's mainly always boluses. There might be a role for that, but I've never seen it being used. Like I said, monitor. The recommendation here is if it's not improved after 3 days, to increase the terlipressin further. The main things you have to consider with terlipressin is a vasoconstrictor. So if you have someone with significant ischemic heart disease, peripheral vascular disease, you can cause a lot of problems with that side. So essentially, baseline ECG, make sure they don't have significant vascular disease and significant ischemic heart disease. If you do have someone like this and you're making a risk-benefit analysis, it's probably safer to go with lower doses of terlipressin rather than going straight to 2 milligrams. Renal replacement therapy, overall, if you have someone who has a established cirrhosis, they have decompensated liver disease, and they've got HRS, their prognosis is poor. So referring them to ITU for renal replacement therapy is only really if you are sure they're going to get a liver transplant, because without a liver transplant, that's the only real fix of some of these HRS patients. A lot of the times you can make them better. They'll come back in a few months' time again with decompensated liver disease. They're generally, with how limited our ITU beds are, unless you have someone who you're using as a bridge to transplantation, it's generally not the right option for most of our patients. Obviously, there's some cases where we do filter them, but it's few and far between. And liver transplantation is by far the best option available for HRS, but it's an option that's only really appropriate for a few of our patients. Again, if you had someone who came in with HRS with acute liver failure, those are the kind of patients, as opposed to the chronic alcoholic liver disease patients who continue to drink, who wouldn't be a transplant candidate. So I think overall my summary really is HRS patients, treat them quite similar to any other AKI patients. Keep HRS in the back of your mind, but recognize it's a diagnosis of exclusion. Make sure you stop all of the nephrotoxic medications, stop the diuretics. Don't worry too much about the ascites and the peripheral edema, as long as they've not got pulmonary edema. You can fill them up. They can have an inpatient drain. You can diurese them later. Early palliative care input with anyone who does have HRS, because their prognosis overall is very poor. And obviously, if you have labeled someone as HRS, you should then consider giving them terlipressin albumin. So sometimes we label them HRS, but then it's first of all an inappropriate label. Secondly, we don't even give them the medications for the thing that we've labeled them as. So it's quite clear that you make a clear distinction between what is HRS and what's pre-renal AKI or medication related. And once you've labeled it, appropriately treat and obviously involve palliative care as soon as possible. Thank you very much.